A little context, I think, is going to be helpful in understanding the development of Belzutifan and why it is likely to play such an important role in the management of patients with VHL. As you know, patients with VHL until recently, and they still continue to be to some extent managed with surgical and ablative techniques, with a view to trying to control the metastatic potential of some of these tumors, as well as prevent these tumors from causing local problems by growing in areas that are critical, such as the brain and spinal cord and eyes, and so on and so forth. While surgical and ablative techniques have been very effective to some degree in managing these patients and preventing some of the outcomes that we try to avoid in these patients with VHL, they come at a cost. There are only so many times you can operate on a kidney before you run into more and more problems before, during, and after surgery. There's only so much you can do before you run out of enough organ to maintain function. So while these approaches have been effective, we've always looked towards alternatives that would make the life of these patients easier while still achieving some of these desired outcomes. With that in mind, a variety of clinical trials were undertaken with systemic therapy agents that we hoped might achieve at least some of the same results that we did surgically without the need for actual surgical intervention. Beginning in the early 2000s, a variety of studies were conducted. Most of these early studies either targeted VEGF receptors, which we know are upregulated and are an important aspect of tumor formation and propagation in VHL-associated tumors. And what we realized over the years was that some of these agents, like sunitinib, vandetanib, pazopanib, do have activity in patients with VHL, and they're able, particularly in the case of kidney cancers associated with VHL, to shrink these tumors to some degree. We have not had a lot of success with other tumors beyond the kidney with these drugs, or had not had a lot of success with these drugs in the past. And most importantly, they all came with side effects that to most patients with VHL were unacceptable. Patients with VHL tend to lead somewhat normal lives between the times they come in to get surgery. So there is a clear desire and a need to preserve the quality of life of these patients with whatever intervention we may choose. And so we don't want to give them something that will affect their day-to-day function. And unfortunately, some of these agents that we've used in the past or evaluated in clinical trials in the past have tended to adversely affect their ability to function to their fullest. So what we were looking for were two things. We were looking for an agent that would be better tolerated, as well as an agent that would be more effective than some of the older agents that we looked at. We've always known from studying the biology of VHL tumors, from the early 90s when the VHL gene was initially identified by a group at the NCI, like Master Linehan, Zavar, and others, to trying to understand what loss of VHL did that led to tumors that included very key findings arising from several groups, including Dr. Bill Kalen's lab at Harvard and Dr. Master Linehan's lab at the NCI, that suggested that one of the things that loss of VHL, which is what drives these tumors, does is increase the levels within the cells of a group of proteins called hypoxia-inducible factors. And these factors seem to play a critical role, particularly hypoxia-inducible factor called HIF2 or hypoxia-inducible factor 2, plays a critical role in driving these tumors. So we've always wanted to try and get at these tumors by targeting that molecule that we believe plays a key role. Developing such a molecule has been challenging. Hypoxia-inducible factors are what we call transcription factors, and traditionally they've been considered very difficult to drug. But work done in UT Southwestern in conjunction with a company named Peloton was able to overcome some of these challenges. Some very smart drug engineering by scientists at UT Southwestern led to the design of some small molecules that would prevent the functioning of these transcription factors, particularly HIF2, specifically HIF2. Once these drugs became available for evaluation in the clinic, we started evaluating them not only in sporadic clear cell kidney cancer, which is also driven by VHL in the majority of cases, but specifically in patients with VHL-associated tumors. The first drug in this category was a drug called PT2385. We did a very small study at the NCI with that drug, and even though the study was small, it gave us several clues that said, this approach is going to be effective in this group of patients. So we were very pleased with the preliminary results we saw with that study. But we found that there were some characteristics of the drug, especially how different people handle the drug or their bodies handle the drug. So we're getting different levels of the drug in different people. We were not reliably able to predict how much drug would be available to act against these tumors in these in different people. And we fortunately had available to us a second drug that overcame some of these challenges. And that drug is called PT2977 MK6842, or now Belzutifan. And we studied this in a phase 2 study with the intent of identifying how effective this drug was in controlling tumors associated with VHL. We were looking at individual tumors arising in different organs. So, for instance, we wanted to know what is happening in kidney tumors, which is the primary endpoint of the study. But we also wanted to look at what was happening in pancreatic, CNS, and other tumors. A key aspect of the study was also to look at the side effects associated with this drug, because, as I told you, it's very important in order to be effectively treat patients with VHL for prolonged periods, have a drug that's well tolerated. This drug was conducted at multiple centers around the country and in some overseas centers as well. And we, fairly quickly, for a relatively rare disease, accrued 61 patients on this phase 2 study, which to date remains the largest study in the VHL population of a systemic intervention. And we were very, very pleased with what we saw. We published these data in the New England Journal of Medicine in 2021 November. For those who want additional details, I'd refer them to that manuscript. But in brief, we saw approximately 90+% of the renal tumors shrink to some extent, with 50% of these patients experiencing what we call a partial response, based on the extent of tumor shrinkage that was seen. We also saw, very nice and reliable tumor shrinkage in all the other tumor organs. For instance, even though we had only a small number of pancreatic neuroendocrine tumors, 90% of those tumors had a partial response. And approximately 1/3 of CNS hemangioblastomas showed a partial response, with a lot more of the CNS tumors actually showing some degree of regression. We've never really had any effective systemic options for patients with retinal hemangioblastomas. And all 16 patients that we followed on the study had some degree of disease control when we looked at what is happening in their eyes, with many patients demonstrating shrinkage of the retinal hemangioblastomas. So this was all very, very encouraging. We also found that these responses seemed durable. The follow-up on the study at the time it was published was around 2 to 2.5 years. And admittedly, for a disease which has lifelong implications, this is relatively short follow-up. But at least during that follow-up, we noticed that most patients who were benefiting this drug continue to benefit for the duration of the study. Two other important things that we were able to decipher from the study. First was that it was much better tolerated than some of the previous drugs that we evaluated. Yes, a lot of patients had some fatigue, and most patients had some anemia, which we knew would happen. Anemia was an expected, what we call on-target side effect of this drug, because this drug interferes with mechanisms that lead to erythropoiesis. And so we expected this, but we found that although anemia was a fairly constant feature in most patients tolerated the anemia well. They didn't get to a point where they were unable to function. In most patients, the hemoglobin dropped initially and then stabilized or even came up a little bit and remained at levels where patients were able to go about their normal lives. There were patients who needed help to keep their hemoglobin up, either with erythropoietin stimulating agents or erythropoiesis stimulating agents like erythropoietin, or in rare cases, blood transfusions to tide them over short periods where they were just not able to make enough hemoglobin on their own. But aside from these, most of the other side effects that we saw were, not very frequent, and most of the side effects were fairly manageable. To the point that most patients stayed on the study at the time of that analysis and didn't feel that the side effects were bad enough for them to be taken off or for them to want to leave the study. So that is a very, very, very encouraging sign. The other thing that we found was that one of the things we'd set out to do with this approach was to try and see if we could minimize the number of surgeries that patients would undergo, because after all, that was one of the things that set us on this path of trying to find a suitable systemic therapy for these patients. And when we looked at that, we found that indeed, at least over the 2.5-year period that we were following these patients under the study, at the time of the analysis that I'm referring to, there were only 3 patients who needed surgical interventions once they started this treatment. If you go back the previous 2.5 years or over their lifespan, you'll find that patients required a lot more surgeries within those timeframes. In fact, if we go back for the past 10 years, hundreds of surgeries were performed in these 61 patients. And so at least with an early look, we think we're achieving a lot of things that we wanted to with this drug. We are causing tumor regression. It's coming at what seems to be an acceptable cost to patients in terms of side effects. And at least for now, we think we have an impact on what's happening in terms of the need for surgery in these patients. So what we've done essentially is taken patient population, alter their natural history. If we did nothing with these patients, the tumors would continue to grow until surgery was performed or something else was performed. And by using this drug, we've changed that pattern. So now patients don't necessarily have their tumors growing inexorably because of this drug, nor do they need surgery as frequently as they did. Longer follow-ups needed to see how well these data hold, but I'm certainly very, very optimistic. And it was based on these data that the FDA approved this drug for use in patients with organ-confined renal, CNS, and pancreatic tumors associated with VHL.